Excellent. Good afternoon, ladies and gentlemen. My name is Harry Young. I'm an ITU registrar and an educationalist from London. Thank you all very much for logging into this workshop. I hope this is going to be interesting and, if nothing else, then a little bit fun for you all. So this is an area of interest for me in my educational research in terms of something that I have a passion for, which is the performing arts outside of my professional life, as well as looking at new and interesting ways to engage learners and use innovative methods for simulation debriefing, which is at the essence of simulation learning practice. So this is something that we did initially for fun last year as part of an established education program, but we've subsequently been looking at ways of moving forwards. So what this workshop is going to entail is there'll be a little bit of guff from me just having a chat through about some of the things that we have done and some of the things that we have found out from the bits and pieces that we've done. And then I think the main thing that you'll all get out of this is a little demonstration. I'll show you one of the TV excerpts that we used as one of our teaching tools. And then I'd like just to have a bit of a general chat about, if you were in the position of either the educator or the learner, what learning you draw out from this and how you might use this to help illustrate teaching points or how to further a certain teaching program. I want this to be as interactive as possible, so feel free to interrupt and ask questions as and when you'd like to. If not, there'll be a spot at the end where we can all just have a bit of a general chat. All right? So I'm going to crack on, if that's all right with everyone else. Now, the key thing when looking at the use of TV medical dramas as free open access medical education in terms of simulation debriefing is the first thing we need to look at is what is the essence of debriefing and why is it so important? When we look through the literature, the key thing from all of the big meta-analyses, all of the papers looking specifically at different methods of simulation debriefing, all come back essentially to the same key point. The debriefing is the most important part of the sim session. It's where we draw out most of our learning points, where we have the opportunity for discussion, for growth, for bringing in people who weren't necessarily part of the sim, for giving people who were part of the sim to look at what they've done and to think about it when they're not under the immediate pressure of the simulation. I'm sure that a lot of the people here who've been involved in simulation have run at least one utterly god-awful scenario where things were an absolute blind disaster. The medical student didn't use the defib correctly and technically killed 3 members of staff whilst failing to save the patient. Someone inadvertently injected one of the other candidates with adrenaline rather than the patient. That sort of thing, where the simulation itself, where the technical learning that has been accomplished is an absolute nightmare. And yet the debriefing from that ultimately comes down to a lot more learning, because you get to take apart all those individual things that have gone wrong and you get to work out why they went wrong and learn from them. So in spite of how disastrous a simulation might be, the debriefing, if it's done properly, is invariably good. And so that's at the essence of this, that the debriefing, in standing alone from whatever the simulation was, the debriefing is a key and important part of this. And so if we can separate that out and separate that type and method of learning, it opens up a lot of possibilities about how it can be utilized. So thinking about using TV medical dramas, and this initially started just out of a bit of personal interest for me and for my colleagues to put this together, because there's nothing I love more than sitting down, putting an episode of Grey's Anatomy on and screaming loudly about, no, we don't do that. Why haven't you pre-oxygenated them before you intubated? No, you're not following the correct guidelines. That is not how you use a defibrillator. And there's a lot of literature that comes out about, there's a lot of literature, particularly in terms of CPR and how badly it's done and potential learning objectives that can be derived from that. But also in general, there's a lot of things that are done badly. in a variety of other ways, and a lot of things that are done well. There's a lot of hidden curriculum role modeling and other things that can be derived from this. And so we took this and we thought, it's like a bad simulation, essentially. So why can't we just use this to debrief? And we thought about some of the advantages. In terms of TV medical dramas, they're everywhere. It's in our research, there were at least a dozen major Western medical dramas that have occurred over the last 30 years, with collective programming amounting to more than 10,000 episodes, and collectively almost 60 to 70 years if each individual show is taken out of overlapping time periods. More than 60 or 70 years of programming, and that's just looking at what's been produced in the West, in the United Kingdom, in the United States, and in Canada. If you take non-English language programming, that expands exponentially. So there's a lot of base material there. This is something, and the fact that these things have been running for decades and thousands of hours of programming proves that they have an ability to engage and get an audience invested. And if you can tap into that, you can get students engaged. When we look at different learning styles, not everyone learns the same way. Some students who are not kinesthetic learners, or people who are nervous and don't enjoy simulation because they don't like getting up and doing something in front of their peers, can get something out of this because they can be brought to engage in watching something and then participating in a debrief without that nerve-wracking experience of having to do the simulation. Although they lose something from not having done the simulation, they can still gain other positive benefits. Atmosphere generation. I maintain one of the worst things in reality is that our life does not have a soundtrack. I absolutely have had, actually, I, on very rare occasions, have had my George Clooney saving a life moment, and I'm really upset that there isn't some Coldplay just playing in the background as I've walked away nodding my head. The ability to generate an atmosphere and investment can bring about a lot of different things for candidates and can help develop deepening investment in simulation. The content is incredibly varied. If you can think of something that you want to teach, from basic science principles up to communication skills and role modeling, there is something somewhere in medical drama that if you're willing to take the time to find it, you can use as the teaching tool. And it's there and it's been made for you. There's very little effort that goes into it. Similarly, you can create rare and unusual scenarios. We know there's evidence in the educational literature of the disadvantages potentially of killing off patients in sim, the risk of psychological injury, and the fact that it can hijack your debriefing. But you can kill people in medical dramas and then debrief it and look at it because you don't have people participating in the sim who feel a sense of guilt or fear or shame about having failed in front of their colleagues. So you can gain the advantages of those types of simulations where you kill off patients without the potential disadvantages. Things that we don't commonly see or that are technically challenging to simulate also medical dramas give us the opportunity to teach with those as well. One of the examples that I'll show you today is a relatively rare scenario in terms of critical care and emergent airway management, but something that everyone is trained to do but doesn't see very often and is technically quite challenging to simulate properly, but you can do it easily. Things such as perimortem C-sections, open chests, malignant hypothermias, awareness in surgery. There is a variety of things that you can simulate using medical dramas that would be more technically challenging or challenging in terms of human factors if you were to do it in an actual sim lab. This stuff is free or it's cheap depending on what you choose to use. And in terms of high fidelity, in terms of being able to make people believe that this is real, this gives you a lot of opportunity to do things in what people can relate more easily than a simulation lab that is very, very clearly not a clinical environment. And it can allow people to relate it more to their practice and feel more invested in the reality of this as a scenario versus some of the things that might potentially crop up in a simulation lab. And as I've mentioned before, the reduction of the potential for psychological and moral injuries with things such as killing patients presents that sort of advantage. So what we did was we had an established ED teaching program, and I was the education fellow in my emergency department. We had a lot of latitude about what we would put on for teaching. There was a regular in situ program, there was a regular tutorial program, but I was by and large given carte blanche to do what I wished. And so what me and some of my educational colleagues thought about was we just included this in lieu of simulation. Particularly when it was difficult to set up sim, because there were certain days when resus would be notoriously busy and it was difficult to take up a bay justifiably or being thrown out partway through. So we incorporated these 30-minute to 1 hour sessions into an established teaching program. We watched a clip as if it was a simulation that was going on. These would be 5-10 minutes at the absolute most, so relatively short for what you would consider to be a simulation. But then we would go on to debrief in a good 20-30 minute session, as you would do for a normal debriefing session. And the points that we generated, either there would be certain key points, for example, if there was a scenario that related to a certain incident or a certain M&M that had occurred recently in the department that we wanted to highlight, we might have pre-generated learning points which we were focused on. But we'd also open it up to other things as well, and a lot of the learners would engage in a variety of different raise a variety of different points, that they had either seen and thought were interesting, or they'd seen and could relate back to their own personal experiences and practice. Anything that we came out of the debriefing was then written up as a formal document and emailed out, and that was just our standard departmental practice for any sort of debriefing session, so that anyone who wasn't necessarily a part of that, dependent on shift work, would be able to still get some of the debriefing value. We learned a few different things from this, and a lot of our participants thought it was quite enjoyable. They thought it was a fun, interesting way of engaging in simulation. They thought it was something a bit different than what they were accustomed to. And a lot of them quite enjoyed the idea of being able to sit and poke fun at something, essentially, which is quite hard to do when it's your colleagues doing a simulation. We had a lot of particularly junior staff, so some of our physician associates, some of our junior nursing staff, some of our SHOs and F2s who were very junior in the department, who didn't normally enjoy simulation because we do interdisciplinary mixed ability sim as our in situ in our department, which meant that you would have everyone from the band 5 nurses up to the senior registrars all mixed together depending on who was available. And the more junior people tended to be more nervous of this, but they found that this was a much easier thing to engage with because they felt more able to speak up, and they felt less intimidated by potentially looking foolish in front of more senior members of the team. It removed a lot of our logistical issues. The amount of times we were thrown out of rooms or resus bays because patients arrived, we suddenly got full up. And we were a large department, and yet we were busy enough that this was not an uncommon event. So in a smaller department, running in situ would have been, in a regular fashion, might have been even more difficult. This allowed us to have a seminar room with a computer and a projector, sorted. So it removed a lot of those logistical issues for us. And it opened up especially the juniors' eyes to a lot of things that they don't commonly see. So I can speak from my background is as an emergency physician before I switched specialty to critical care. And in the 6 years I spent as an SHO and a registrar practicing in emergency medicine, I have seen one open chest. There have been multiple ones. I worked in one of the busiest trauma centres in London, if not the busiest, and yet it was just through luck or a variety of other reasons, I never got my hand inside of a thoracotomy, in spite of the frequency with which they occurred. And so a lot of other things similarly occur in terms of precipitous deliveries, perimortem sections, lateral canthotomies, etc., that either don't occur very often or that occur and the seniors immediately get involved and the juniors don't get a look in. So especially for the junior side, but also for some of the seniors, it let them experience simulation of some very interesting technical scenarios that they would never normally get to see for one reason or the other. This wasn't without its issues. For example, screen and sound availability was a problem. We had one particular issue whereby we ended up with 8 people crowded around a very small computer monitor trying to run this session after our sound packed in. People who did enjoy the active simulation said that this was fun. They liked it as a bit of a change of pace, but they wouldn't want it to replace the entirety of the simulation program, which was a perfectly reasonable thing. And they enjoyed the actual dynamic thought process and the team building skills that you don't derive from this. And so that is one of the disadvantages here. And also in terms of the debriefing, when you look at older models like Pendleton, when you talk about, so what did you do? What went well? What didn't go well? How would you do it better? This doesn't mesh very well with that. Our education academy and our departments largely use the Diamond debriefing tool, which meshes a lot better with this. But depending on the debriefing tool which you're accustomed to, this doesn't necessarily work as well. There's obviously some legal issues that arise from this, but we had an advice of evidence from a solicitor acquaintance of mine who basically explained to us that in terms of the use of medical dramas for educational tools, we're covered at least under UK copyright law by what's known as fair use or fair dealing. This is the circumstance whereby if you're using small excerpts of something for the purpose of education or critique or parody, it is legally permissible. I can say that similar things occur in a similar law is present in the US. Depending on your legal jurisdiction, I'd say just check what the legal guidance is from your country, but it should be available. There's a link in here to the actual British government's guidance. And I think one of the key things is, as you will see if you go on things like Dr. Mike on YouTube and other YouTube channels which do reviews or parodies of medical dramas, the key thing is that you have to headline that you don't have ownership of the material that you're using, that it's being used under fair use, and the reason for which you're using it. And that essentially provides you with legal coverage. But like I said, there is probably some variation by jurisdiction. We did this and we never had any issues, nor do we reasonably foresee any. Now, let's put this in a little bit of context. And I think the best way that you'll understand how this can be used is to actually see it and do it. So what we're going to do is play a short clip for you. It's actually the first one we used as part of our teaching program. It's from a medical drama called Trust Me that ran for 4 episodes around about 3 years ago now. And it stars Jodie Whittaker, now of Doctor Who fame, as a nurse who steals her friend's medical school transcripts and poses as an emergency medicine registrar. This is an excerpt from the 3rd episode, and to give you some context of the background, essentially, it's 2 doctors in an understaffed, busy A&E on a Saturday night. I think we've all been there at some point. Jodie Whittaker's character initially sees a gentleman with a submandibular dental abscess wanting to be seen by the maxillofacial surgeons. However, her boss, due to departmental pressures and a variety of other things, says no, antibiotics, get him out, at which point he will subsequently represent, which is when we come onto the clip. What I'd like you to do is, while we're watching this, it's about 5 minutes long, just watch what goes on and think if you were a student participating in this, or if you were an educator using this, what sort of learning you would try and draw out. It can literally be anything. And then just see how this relates and think about it in the context of how you would debrief this if it was a sim. Okay? So moving on to the video. Okay. I'm going to give everyone just a second because obviously that was rather intense. And then can I just ask people, feel free just to unmute and pitch in as and when. Just generally speaking first, what are your thoughts? Thank you, Anna. So, it did seem very real. Can I ask, has anyone ever been not necessarily in the same situation, but in that sort of oh my god, everything is kicking off sort of moment? So what are people's thoughts about how real that felt to their experiences of being in this sort of situation? Oh dear. Sorry to hear that, Anna. Okay. So I think the consensus here is that this felt very real, and people have been able to say, "Wow, I can relate that to my practice." And I'm very glad someone just mentioned video laryngoscopy because that's actually something that came out of this. And we did a whole different sim and debrief based on that. And yet you can feel the rising panic, which is my statement earlier of this is why life ought to have a soundtrack, because normally it's just deathly silence, and sort of that doesn't really help. Can I ask now, and everyone just feel free just to unmute and pitch in, if you were doing a sim debrief on this, what would you pull out? What learning points would you want from this? Yeah, so team working and lack of an algorithm. So please, everyone, feel free to speak as well as type. If anyone wants to just elaborate on a point.
Hello?
Hello, yeah. Please go ahead.
Yeah, hi. This is RL from Austria. I'm an anesthesiologist. I was impressed with timekeeping, the situational awareness of one of the junior nurses. I also was impressed with the mutual support the team gave each other, especially the second intubator and the junior nurse. So they supported each other, and they came together to the decision to make the surgical airway, and I would expand on that in a debrief.
Yeah, so that's a really good point. So just to draw out a few things from that. So yeah, I think there's a good point about role modeling, and particular role modeling for junior staff, and encouraging freedom to speak up, freedom to make suggestions, which she was doing because there was a consultant and there was a registrar there, and yet she was the one pushing them to make decisions. And for those of you
right.
within the UK, I'm assuming a lot of people have heard about Elaine Bromley. We use it quite a lot for teaching about a can't intubate, can't oxygenate situation whereby 3 consultant anaesthetists were failing to intubate, and there was a nurse standing there with a crike tray ready to go that was never utilised because she didn't feel able to speak up. And so thanks, Aurel, that's a really good example. So I think there's role modeling. I think there's about communication between the two of them. I completely agree with that. Does anyone else have any other thoughts about specific things that they'd like to bring up?
Hi, am I?
Yeah, please go on.
Hear me? Yeah, hi, this is Annalena. I do work in the UK. I'm an anaesthetist as well, just as oral. Just to say, I didn't really get their rules, which is quite realistic, isn't it? But I think, was it the consultant emergency doc who then asked the registrar to have a go at intubation? Did I see that correctly?
Yeah, that's correct.
Okay, so I just felt, because Oral said about mutual support and, you know, the team working together well, I would probably debrief a little bit along the lines of how would that make you feel if you were in the position of the registrar? If you're clearly struggling, obviously I wouldn't put that in the debrief, but that's my thoughts. If you're clearly struggling consultant, then hand it over to you saying, you go next. I mean, that was something that I felt really stressed about.
Okay, that's a really good point. That was actually not something that came up in the debrief, but that's a really good point. And in terms of how you might approach that, what I would initially probably lead with is just by asking an open question to make people feel more comfortable by saying, does being the consultant mean necessarily that you are always the most experienced or best placed person to do something? Which I would argue is no. So a good example would be on my unit, we have a mixture of anaesthetic intensivists and physician intensivists. And we have a senior registrar at present who's a consultant anaesthetist back in his own country, but is only a registrar here. And we ended up in a situation with a very difficult airway where the duty consultant was a nephrology intensivist, very experienced, very able, but he felt completely okay to hand over this complex airway to the registrar, who was, by dint of his background, more experienced. So I would probably lead with that by saying, are there situations where someone more junior can have more experience under certain circumstances? And leading on from that, then I would ask people if they could think of certain circumstances where that might be relevant to them, rather than asking them to go into any personal experiences of, has a consultant ever dumped something on you? Because obviously that has then the potential to spiral and take over your debrief. So that's a really good point. I think I'd be cautious of how I brought that up, but that's a really good point that we didn't actually mention when we used this session, but I will use for the future.
Can I just quickly add something, Harry? Because is that okay? I absolutely agree with you, but my perspective, what you said is very valuable. I actually hadn't thought about it from that perspective, but yes, definitely a very good point to open up the discussion, whether it's always about your role or could it be about your expertise as well. But what I meant was, my perspective was more from the point of view to open it up to the group and ask, how do you think this person could have felt in that situation? Because I don't know about all the other viewers now, but when I watched that scene, for me, it was pure discomfort. The looks the two of them gave each other, I felt the registrar wasn't very comfortable with that situation. I don't know how everybody else felt, but I just felt discomfort there. And I felt like something was delegated, maybe not in mutual agreement with the person accepting that, not as a challenge, but more as a very uncomfortable task. But I'm not sure that was only me seeing that. I don't know.
That's a fair point. Does anyone have any thoughts on this? No, that's a fair point. So so we've got a few people agreeing. In terms of the point that's just been made about looking at the limitation from the point of fact that this is a drama and we're not looking at reality television, I think part of the discomfort you're referring to is actually relevant to the story. which is the fact that she's not which the registrar's not actually a doctor. She's never done this before.
Oh yeah, I forgot. Sorry. Yes, of course. That makes sense.
And so that's adding an extra layer in. But equally, I think if we look at this in isolation, just remove that fact, I think you can still make the same point and ask, how are they feeling? Did she adequately communicate? I don't think I can do this, which even a fully trained senior emergency medicine registrar may feel completely unprepared to do a difficult intubation that their consultant has already failed at. So I think that's a really valid point. Just moving on very quickly, because I'm conscious that we've only got 10 minutes remaining. There's a question from Piotr about how do we transfer the experiences from the movie to the students to analyze and discuss in the debriefing. Essentially, I would approach it like I would a normal debriefing session, which is I would use the diamond tool and I would say, okay, let's describe what happened. And you go through it and you describe what happened. And then you analyze the individual components, talk through them and say, okay, so at this point, patient arrived, they couldn't get access. So who's had these experiences? What would you do under these circumstances? And then you look towards your actions at the end. It's like, how are we then going to relate these different points into learning practice? So essentially, I just follow the same structure that I would do for any debrief. And I just relate it to this, but asking them what, and you can remove the, how do you feel it went? How did you feel coming out of that? You can add that in, especially if it's a particular traumatic scenario like this one. But normally I would just follow the same standard debriefing tool that we use for anything else. In terms of a question from Elisa, in terms of handling medical management and current guidelines or focusing on non-technical skills, I actually like to do both. So I think it depends on your audience, but I find that a lot of my audience, they like the non-technical stuff, but a lot of them want to get clinical knowledge and value out of this. So I do try and relate stuff, particularly to modern practice. If I'm using older medical dramas, like there's a certain episode of ER from 1995, that I'm very, very fond of. When I use that, it's blatantly out of date. So much of it is out of date. And we talk about the latest evidence, the latest publications, the latest guidance, and how we would do things differently. So I do relate some of the modern clinical practice to this. If we're using something very, very up to date, it's a lot easier, and we can say, have they or have they not deviated from current standard guidance? Whereas if it's something older, we can say, well, what we would do nowadays is this, and this is why we might have had a better outcome. So that's something that I like to do. But we also then look at the non-technical stuff as well. So it very much varies depending on what I want to get out of it, depending on the learners that are available. Sorry, I'm just reading through some comments just to see if I can answer some questions very quickly. In terms of the question just put in from Jim Horn about with so much content being available, how do I find the right clip for my session? So unfortunately, this comes from the fact that my job is also my hobby, and the fact that I watch a great deal of medical dramas, partly because there's something quite enjoyable about sitting down and smugly going, I wouldn't have done that. But also, it's how I process and prepare things, and I sim a lot of things in my mind. It's my process and how I work things through. So I have a lot of experience of watching things and knowing that, oh yeah, that's something good because that's how I remember how I go through the difficult airway algorithm, or that's how I remember the steps for a subclavian line insertion, or that's how I remember this, that, and the other. So in terms of knowing what to use, all I can say is you need to essentially just watch a variety of things and try and work out how they fit into what you're wanting to teach. I'll give some recommendations in terms of I strongly recommend certain aspects of ER, Grey's Anatomy, Casualty from the United Kingdom, things from The Resident and Code Black from the United States. Trust Me is another thing, and some older series from Jed Mercurio, who wrote Bodyguard and In the Line of Duty. Things like Cardiac Arrest and Bodies and Critical. These are all available on a variety of different streaming services. So all I would say is look through different programs that you have personally enjoyed in the past and try and tease things out, or look at Wikipedia entries and try and work things out. I don't have a good recommendation beyond have a look and see what you enjoy. In terms of using stuff from reality shows, personally, I would like to avoid that, largely on the ground that it's reality and it's easier to get some degree of cognitive dissonance when it's a medical drama and for people to walk away. Whereas if something's real and they've seen something traumatic happening, that's quite difficult to step away from. Just moving on very quickly. So when we did this discussion, some of the things that came up are, so we broke this down largely into comms, clinical, and CRM. So when we were looking at the comm skills, we were looking at the indecisive leadership of the consultant, the fact that she was giving nebulous orders like anesthetics, ENT, both. Unclear instructions, similarly. Failure to verbalize when she was intubating, which meant that it became rapidly obvious that she wasn't able to intubate, but there was no statement of, no, I can't get a good view here. Clinically, we talked about considering IO versus IV access in a difficult flailing patient who you need to rapidly sedate. We talked about the DAS algorithm, so relating to what was said earlier about relating this back to clinical practice and relating this to modern guidelines. We had a good teaching session on the use of the Difficult Airway Society Can't Intubate, Can't Oxygenate algorithm and how they should have approached it using the ABCD formula. We talked about video laryngoscopy, and we had an anaesthetist co-debriefing this session who said that using something like a glide scope or a Macril or a CMAC would potentially have ameliorated the situation. And then we talked about the proper Crike method because they used a Shiley tube, whereas the current DAS guidance is for a 10-blade, a bougie, and a 6OET tube. Looking at CRM, we talked about planning ahead. They knew they had a difficult airway from the second the red phone call came in, and yet they didn't bleep ENT and anesthetics until after the patient had arrived. So there was things about thinking ahead. We talked about leadership and followership and how relevant that is in terms of handing over and how they communicated, how there was no clear leadership throughout. No one got out a copy of an airway algorithm, and we talked about not calling for help early. So just to summarize this very quickly, so what this is it's a bit novel, it's a bit fun, it's a bit different. People find this enjoyable, they find it engaging, they find it enthralling. And the atmosphere generation that you got from that music, everyone was saying how they felt quite on the edge of their seat, quite afraid of what was going on. And so you can get the same emotional investment that you can get from a simulation. You can use sim-style debriefing, but you don't have to be in a sim lab. You can be in a seminar room, you can be in anywhere else, and it opens you up to a variety of different potential ways in which you can use sim-style debriefing. And you can teach so much stuff from it. You can look at CRM, you can look at common skills, you can look at clinical factors, but you can teach a variety of different things to a variety of different groups using this. To emphasize, this isn't meant to replace simulation. As I said earlier, people do enjoy sim, and you don't get the same human factors, team working skills, and you don't get the practical hands-on, I will remember this, in the same way that you do from running an actual sim. This isn't just a little bit of fun. This isn't something that you can be like, oh yeah, that's a bit nice, without thinking through what you want to get out of this. And then ultimately, this isn't something that you can't just, it's not like year 2 at school where your teacher hadn't prepared a lesson plan and you can just whack on a video when it's wet outside. This is something that has to be planned and that you have to think through in order to actually get some educational value out of this. So the key thing is, it's not a last minute, oh shit, I've forgotten to prepare my teaching session. It is an actual teaching system that you have to prepare for. In terms of, there's some referencing here. I apologize that they're so small. I tried to cut it down to only the key things. But these are some of the references we use. There is a lot of literature out there. They've used education for a variety, they've used medical dramas for a variety of different educational methods in various countries. So have a look through the literature and see how things fit into your department, into your educational style, into how you want to run sim. But ultimately, this is very applicable from everything from teaching medical students about how to talk to a anaesthetist, how to handle complex airway issues. There's a lot of stuff out there, and you just need to have a look and think about everything and think, how can I relate this, and do I want to relate this to my current teaching? I realize that I've gone over, so I will very quickly ask if there are any questions or any other points that anyone would like to make. Feel free just to unmute and jump in, and then we will close off. Excellent. I think that's everyone. So if no one has anything else that they would like to ask, I hope this has been enjoyable. I hope that I've given everyone something to think about, and I hope that you've seen that this is something that can possibly liven up your sim program, and that you can use both in a sim lab, and also, key point as well, as remote learning during COVID times, this can potentially be an absolute godsend. So thank you very much. And if this is everything, I will end this there. Thank you for your time.